Adam from RHTP Experts, and in this video I'm going to be talking about the relationship between rural health transformation and public outreach and engagement, and why it's so important to engage your community, your workforce, your patients in your rural health transformation initiatives. If you don't know who I am, well, hi, I've been working in rural healthcare since 2019. We've worked with about 175 clients across our companies. We started out in workforce and recruitment. We've got 20 nurses to accept job offers in Alaska, and we've probably engaged about 15,000 members of the workforce since 2019. And in 2025, a lot of our clients across our workforce engagement and our marketing division said to us, "Hi, Adam, we really like what you do, but we don't have enough money. And it's a real challenge for us to get our communities involved in the new initiatives that we release, if we can release them at all, because we don't have any money." We've seen this new government program come out, the $50 billion Rural Health Transformation Fund. How can we take advantage of it and finally get the funding that our initiatives need to make them actually work? So at that point, we opened up RHT Experts as an area that really focuses on helping healthcare providers like you achieve rural health transformation. So I'm really excited to be focusing on this topic and bringing rural health transformation tips to you today based on our experience working with clients across the US. One I want to highlight is the Colorado office of eHealth Innovation. I'll be talking a little bit about how we work with them today, particularly on a telehealth initiative. Did you know that over half of people in rural Western Colorado who don't have access to telehealth don't actually want to have access to telehealth and wouldn't use it if they did have access? I'll be jumping into a little bit about that today and why public outreach is important to bridge that awareness and interest gap to make rural health transformation actually work. So whenever we talk to rural healthcare leaders, and we've helped about 10 with their rural health transformation program applications, we always ask them, what's the single biggest challenge you're experiencing right now? And it comes down to 3 areas. Number 1, revenue. So the one big beautiful bill, or whatever you want to call it, is going to be cutting Medicaid as we go into 2027, and people are already preparing for that now. There's going to be a rise in the uninsured population, and net patient revenue is going to drop for a lot of critical access hospitals, rural health clinics, FQHCs, and the rural health system as a whole, which relies on those big anchor facilities. The second is cost. So wages have risen on average about 5% over the last 12 months in rural healthcare, and there's a shrinking pool of qualified staff. Just think about how much were your CNAs or RNs earning before the pandemic. I know that comparison is getting a bit difficult now as we go like 6 years after 2019, but it's gone up for a lot of these jobs over 20, 25, even 30%. CNA is really pushing that higher. And this is a problem because as costs go up, revenue isn't increasing enough to match that and is compressing on margins. What does compressed margins mean? Well, facility closures, service deserts, and general contraction of access to healthcare in rural areas. So I'm sure you're all aware of this. But when it comes to planning rural health transformation programs, particularly using this $50 billion grant we have out right now, most clients want to use those programs to solve these issues. And while the feds have said you can't use the rural health transformation program to replace revenue, I want to help people think about this in a different way and consider how replacing revenue is one thing, okay? But another thing is bringing in new streams of revenue and reaching new patient populations. And it's not doing the same thing that didn't work again. It's broadening where you get revenue from, but also new initiatives to cut cost. So how can you think about staffing in a different way that reduces the wage bill, which accounts for over 50% of costs in most critical access hospitals? And I think we can use the Rural Health Transformation Program to do this. There's three things that our clients care about when it comes to planning the Rural Health Transformation programs: success, compliance, and improving margins sustainably long term. So when it comes to success, they want to improve health, they want to improve access. They live in these communities. I'm sure you live in a community where you come into contact with your neighbors every day and you understand their healthcare needs, you know their names. And it's important for you to see those changes in families and neighbors, and you want to fix them. You want people to have better health. Compliance too. So staying accountable for this big federal program, for example, you're going to need to follow federal procurement guidance. How do you do that? I did a webinar on that last week. You can go onto the channel and see it. If you don't do that, you might have to give back money and you might miss out on funds for the following years. And then finally, as I've mentioned here, improving margins sustainably. How do we use this program to solve the financial quandary that we find ourselves in within rural healthcare? So as I go through this, have a think. What's challenging you? What do you want to fund? And what rural health transformation initiatives do you think you could use? And what could you send the people that you're doing public outreach to into? Because here's the thing. Most rural health transformation is about build it and they will come. We have heard that, it's a term in society, but it's a term often stated immediately to be a fallacy, where creating a new program isn't the finish line. It's like building an engine. Without someone driving it, it's not going to go. It's not going to get very far. Build it and they will come as a fallacy. And think about the programs that you've done in the past. I like to highlight recruitment for this. So consider the recruitment initiatives that you've implemented to solve your nursing or physician staffing crisis, right? Is that a sign-on bonus? Or is that a marketing campaign in the next city, or an ad in the newspaper, or streaming ads if you're getting technical and advanced about this? Has it worked? Maybe some of them did work, maybe some of them didn't, but I'm sure that you'll recognize it's hit and miss, and it often depends on how many people are actually interested in what you're offering. So if you're holding a whole new host of benefits for physicians to come work with you, nobody responds, there's an awareness gap there. Like the public outreach hasn't driven people into that offer, or the offer isn't good enough. So this webinar is really for those that have thought about what their offer is, what is their rural health transformation program initiatives, but then aren't too sure how to drive people into it. And that's the important part that I want to help you with. How do you drive people into that great initiative and program you have built? Could it be a new college center you've opened up to train community health workers? How do you get people interested in that? How do you do the marketing and the public outreach to drive traffic? Because recent studies on rural health have shown that while 90% of executives are deploying telehealth, for example, nearly, as I said, 50% of rural patients are unsure about it, and they insist that it's critically important to have a provider physically in the room. So with our work with the Office of eHealth Innovation in Colorado, we looked at that study they had, and digging into it deeper, there's mistrust on data privacy and data collection. If I'm telling people my deepest, darkest secrets about my lung cancer, for example, or my depression, where is that going in terms of data logging and the cloud? Because there's always going to be a middleman that's collecting that information, who's providing the software. And people are wary of that. They also are unsure about the standard of care. I share this belief and tendency actually, where if I'm going to go to the doctor, it's going to be better if the doctor can examine me, right? And how can providers of telehealth challenge that and tell people, well, yes, it's important to come to the doctor for this type of condition or these type of symptoms, but for your type of symptoms, it's fine to do this over phone or over video cam. And that's actually another thing that I hadn't thought about before we did that campaign. Whenever you mention telehealth, particularly to a lot of older people, so over 65s, the survey found that they often perceived it as being provided from the screen of a computer or laptop. They hadn't considered that it can be done over telephone, even though it's called telehealth. So the screens are sometimes associated with the learning process that someone had to go through to get techie. And I know certainly for my grandparents that was difficult and often scary. So whenever we jump into communicating with people, we have to do it on their level, taking into account their life experiences and their awareness, capability, and perception of different technologies or different career opportunities or different pathways in life, so that we're helping showing them that complication can be boiled down to simplicity. Another part of this is on the compliance part. So why is public outreach important for compliance if you're doing a grant-funded rural health transformation program? Well, for better or worse, we are officially in the Doge era of government. Just in the last year, the Trump administration has disrupted over $12 billion in previously awarded federal funds, including the abrupt termination of hundreds of ongoing competitive grants worth $2.2 billion. So the Rural Health Transformation Program, for example, is a 5-year grant program. There's two risks involved with that. The first is that your state might face what's called a clawback, where if your state doesn't spend all their money, or if they spend the money in a way that the feds find to be wasteful, fraudulent, or abusive, the feds are going to come and ask for some of that money back, or more likely, just give your state less money in the next year. And that's bad because it reduces the resources in the pot and the system in your rural healthcare system. The second part is for you as an organization, individual organization, because it's a 5-year program, year one has to be done right by you because it's only 20% of your total potential grant pot. If you don't get year one right, if it flops and nobody engages with your programs, well, in year two, you're probably going to get less money. And you've proven in year one that you can't achieve metrics, which are important, relating back to the Doge point. So if you go cap in hand and say, well, okay, we didn't get anyone interested this year, but give us more money, that money will probably be put into initiatives that have shown a bit of traction and shown that they can get off the ground with people engaging them and patients coming into the telehealth pipeline that you've created, for example, or workforce applying to your upskilling programs, or people applying to your positions to move in from different areas. You don't want to be flagged for underperformance because it could cause an audit, and then it could cause that audit to lead to the 80% of year 2 to 5 money that you might have gotten to not go to you anyway. And why is that important? Well, back to the financial point, it all goes back to the fiscal situation of rural health. These funds can't be used to replace what you're losing, and you don't want to lose out on these funds for year 2 to 5. I also think that it's important not to keep advocating. Not to stop advocating for more funding in the rural. It's not being pessimistic and saying, okay, we can't use this money to replace the losses from Medicaid cuts. That's it. No, keep advocating and talk to your legislators and get out there that this is still ongoing. But when it comes to this grant pot, I don't want you to discount it as an opportunity to create new revenue streams and cut costs. The federal administration see this as startup funding to open new pathways to get finance, new ways of doing fiscal sustainability, and also reducing costs around staffing. we know that a lot of rural facilities still use temporary staffing agencies and travel nurse firms. And if you can get a more permanent body of nurses, be that through an internal float pool, people recruited in from afar, or your local college expands nursing program, then that's going to cut costs long term. You're saying to the state here, we want to spend, say, $1 million on a program. You need to show how that's going to generate at least positive margins in the future. And I think it can. But you need to get people engaged in whatever you're choosing to fund. In past webinars, I've spoken about past initiatives that didn't get people engaged and they didn't do outreach effectively. So, as an example, there was a company called Canadian Health Labs that was engaged by the state of Manitoba in Canada. Sorry, province of Manitoba. Excuse me, Canadians. Do forgive me that one. The province wanted 150 physicians because massive province. My colleague Patrick is from there. He's from a town called Dauphin, which is kind of one of the northernmost towns. It takes several hours to drive to Winnipeg, and very remote rural communities up there. They wanted 150 doctors to be spread across the province, and the company that engaged only got 2 doctors for that 150. They got 2, and that's like less than 2%. So why didn't that work? Well, there must have been an issue with communication and engagement and potentially the offer that the state was giving them. Flip that about, and British Columbia managed to, I think it was 5x the number of nurses and doctors that were relocating into them in 2025 versus 2023, 2024. And they did that through a really snazzy marketing campaign that spoke to people in the US who were sick and tired of like political situation, culture wars, and current politics. I know some of that goes on in Canada anyway, so the grass isn't always greener, but a lot of people were interested, and through a campaign that really spoke to those issues and marketed it to them, spent a couple of $1 million on the marketing itself, they managed to greatly increase the number of clinicians that were moving north to British Columbia. So why does this matter? Well, if you weigh those two campaigns up, and you can go and Google them, there's a difference there, and we have to think, why was there a difference? I think that a big part of it was how things were communicated. British Columbia released videos. They brought in a branding firm based in Vancouver to really devise what makes British Columbia relevant and interesting to nurses in like California and doctors in Washington. And how can we play on that and market that? They even did some advertisements, like I'm talking billboards and coffee trucks outside hospitals in the US. If you flip it around, Canadian Health Labs in Manitoba, I'm not putting loads of blame in them or dissing them, because here's the thing. That contract that they were on, I believe, is a contingency recruitment contract. That means that if they hired a doctor, they would get, say, 20 to 30% of that doctor's first year salary. That doesn't leave loads of incentive or opportunity for a firm like that to go out and invest loads in public outreach. And by public outreach, I'm meaning outreach to physicians, marketing, like what they did in British Columbia, like a branding campaign, paid advertising, because you're only getting the money if the doctor's hired and if they stay. And recruiters, we don't really like spending money. It's more about, right, let's hit the phones, or let's send some emails, or let's send some messages on LinkedIn. But you can see here the difference here in these two rural health transformation projects was that in British Columbia, they did invest in the public outreach, and they had a great offer at the same time. So they were making licensure really simple, really quick and easy, slashing the time that it took for US physicians to get licensed there, and matched it up with a good public outreach campaign. So do have a look at those examples online. And I think it was a bit embarrassing for the state of Manitoba to be associated with that. And that's a risk of the Rural Health Transformation Program in the US as well. You don't want to be in the news for wasting this money. And I do think that the Feds, thinking back on Doge, are going to be in the lookout for examples, particularly if you're in a democratic state, a majority Democrat state, where they're going to be on the hunt for projects that didn't effectively achieve the metrics that they aim for. You got to watch out for that. And I do think that now more than ever, it's crucial that you consider, well, how are we actually going to get people to engage in our programs? So I want to call back the example that we did in Colorado. So we had 11,000 extra people seeking information on accessing telehealth. And we did a campaign in Southeast Alaska to get nurses from the lower 48 to move in, and 20 accepted job offers in 3 years. So for both of these, we came into a situation where telehealth was available in rural Colorado, western Colorado, and those nursing jobs in South Alaska were also available and were being marketed. But the difference was how the public outreach worked and how we handled it. So how did we get that 11,000 people extra doing it? Well, we created a website, mini site, explaining what telehealth is and what it isn't, challenging some conceptions based on research. We did a marketing campaign on social media and in local community newspapers. We also reached out to trusted messengers, which are healthcare providers like physicians or hospital system administration, and said to them, will you help us explain to your patient population what this is and what this isn't, and encourage them to use telehealth. And trusted messages are extremely useful in rural communities, and that includes newspapers, but it also includes the mayor, it includes the local council, and people in positions of authority, even the sheriff or the fire chief. We underestimate the respect that people have for office and how influential people in communities can actually affect a lot of change. And if you're doing a public outreach, be that marketing on social media, be that emails, print, if you can have the voice of a community leader backing it up who appears in those ads that you're sending out, then it's really helpful. And if they're sending them out themselves, like if they're handing out flyers, maybe the mayor wouldn't be doing that, but if it's in like their office or they're talking about it, then it's a multiplier, force multiplier on what you as a healthcare provider can do, because often people mistrust healthcare systems, particularly larger ones, and they want that personable one-to-one point of contact and relationship to change themselves, and they need that trust there. So creating different touch points of trust is important. And public outreach again comes back to 3 steps if I've convinced you that it's important to integrate it. So the first one is to define why your community should care about the program that you're releasing. So let's talk about a new center to train up CNAs and LPNs, keep them within the rural community. Let's say we're in North Bend, Washington. We don't want people to have to travel over to Seattle through the pass to get training. We don't want to lose them from the community. They might stay in Seattle if they leave. How do we keep them in North Bend? We create a grant-funded center. We hire an educator. We bring in the curriculum, and our first cohort is ready to go September 2026. So day 1 arrives and 5 people show up. We were hoping, and we told the state that we were going to have a cohort of 20 people. Looking back, why was this? Well, we launched a program, we did create a website, we sent emails around, and that was it. We didn't get enough people aware of the program, and we didn't think broadly enough about where they could come from. We just advertised it in the local community, and we thought that if we build it, they will come. What could have been done better? Well, a really thoughtful, strategic approach that considers how do we get the maximum number of people interested in the program. So it's oversubscribed. So there's too many people interested and we have to turn people away. So that includes a digital marketing campaign, not just in the local community, but further afield. So we actually get people traveling into us rather than traveling away. We talk to local housing providers and how could we kind of connect potential students with housing options. We get the educators to create videos for us that we broadcast across Facebook and TikTok to really create a buzz about this. We communicate with the local newspaper. We want to make sure that everyone in this community knows that this program is launching, to tell their friends and to invite people from other towns and small villages in the state to send their sons and daughters who are working outside healthcare. Maybe they're working in hospitality, maybe they're working in retail, maybe they're working in the services sector, maybe they're a student who's just finished high school and they're considering what next. Let's engage them, let's bring them in. So that's really defining how you reach out to people. And to make it work, you need to understand what they care about. So why would that new high school student or old high school student who just left care about becoming a CNA or an LPN in North Bend, Washington? Why would they do that instead of going into a job at Target or moving in Seattle to get a job in an office or working with the land? You know, what would they care about? Like, is it better wages? Is it job security? Is it making an impact and looking after people? Is it care for the community? You need to think about that and talk to people. Talk to people who are working in healthcare in your area, preferably the jobs that you want to hire for, and write it down. So you're defining there what is the brand and why should people care about it. Spoken a bit about like potential types of campaigns you could do. And the last bit is really like the conversion. So once people have been aware and they're participating, how do you follow up on them? It's not as simple as building it and they will come. But once they've came, even to open the door and push them through it, you need to be calling them, you need to be texting them, emailing them, and really just approaching this from a almost a sales standpoint too. So you got your program design, maybe your best program managers, clinical team, CEO are looking at that. Then comes the marketing. So how do you get people engaged in the public outreach to come into the program? And then it's always thinking out the sales step. So how do we actually get them to sign on the dotted line and take that final leap to become a student or to apply with you? Too often, people just think that step one is all they need to do. And Grant will give them the money, they'll do it, and it'll work. But to really make it have a long-term impact on revenue, cut costs, improve margins, and avoid that clawback and audits and not getting money years 2 to 5, you need to make it work and you need to think about how you're doing the public outreach piece. So a few more tips on how to do that. So consider how you can be strategic with your message, the line of your community. What channels would you use to do the public outreach? And how can you keep it all compliant? So how are you going to track? Email sent is easy, but how many people saw your flyers, your information, like scan the QR code, for example? Or how many people you followed up with on the phone? That's all really important too, so that you can prove that you've been compliant to the program. And because it's a federal program, compliance is going to be tight. And you need those metrics, and I think they're a very very useful part to have, even if you're doing a type of initiative that's about, for example, interoperability or a new EHR that isn't necessarily about engaging the public to make it work. You still need to show metrics involved with that. And for those ones, if you're doing new initiatives, you need to communicate it internally. And what I'm talking about here extends to communication within your own organization as well. So how do we get those staff that are set in their ways with your current, perhaps manual paper charting system to get onto a Epic or get onto a new charting system? Do work on outreach around that and track it to show that you've made an effort to encourage uptake internally. This extends to any type of program, I think, because you're going to be going to outside community stakeholders, or you're going internally, or maybe you're even going to both. And you need to think about how you're doing the outreach and you're tracking it too. So I hope that I've convinced you to add an extra problem to your list of problems. But really, this is a solution, okay? This isn't a problem. This is about how do you take a great initiative and program that you come up with for rural health transformation and then make an outreach strategy, be that internal or external, to make it work. This is the secret ingredient, I think, to making great rural health transformation initiatives successful, driving net patient revenue, driving lower costs, and driving improved margins over time. Like, this is the secret to make them sustainable, and you'll learn a lot if you drive enough people into those programs, because then you'll have your test cases too. RHT experts, we can help you with this. If I've kind of overloaded you with a lot of marketing speak or public awareness speak, don't worry, we can help unburden you with this. So if you're planning your rural health transformation program initiative, if you've applied already, or if you got funded, send me a message, Adam Chambers on LinkedIn, or Adam at applychat.com is my email. We'd be happy to talk you through our approach to this. Essentially, our clients are giving us the public outreach responsibility and saying, we're going to build a program. You guys get people to come into the program. So we help turn RHTP dollars into long-term improved margins by actually building revenue streams out of those grant-funded programs and avoiding the compliance dangers that could exist with not getting enough people to engage them. We come in, we do the steps that I outlined in my previous message. So it's about coming in and thinking about your strategic messaging, your community alignment, figuring out what channels you should be using to engage people, and then activating the campaigns to make this channel work. And then we do the follow-up. So like phone, email, text, whatever it is, to get people to actually come in, walk into the door, and start becoming a patient or become a trainee or become a new employee. That's where we can come in to help you make your programs work. So you can, by all means, reach out to me and learn more about it. I'm sure there's links everywhere if you look up RHT experts. And if that's not your plans, then we'd love to help you anyway. I'd love to just share ideas and learn about what you're doing to transform rural health. So I hope you find this useful. Hope you enjoyed this video. And remember, public outreach is essential to make your rural health transformation program work, be that internal or external. And use what I've said in this video. I think it'll take you quite far.